Okay, good morning, everybody. Everybody here in-house too. I'm gonna go ahead, we're gonna get started. Sorry, we're a little late just getting tech stuff set up here. But we have our you want to just say I just am recording it, so that's why I'm getting a little some kind of we have some friends from cysview. I'll let you guys do your own little introduction if you like to tell a little bit about the company or like why you guys are here and all that stuff. Antonio and Angela. So please give your attention and hopefully we'll learn a little bit about the cysview product.
Everybody, I'm Angela, and I am the representative for Michigan for cysview. And the purpose of the visit today is to provide a refresher on the reconstitution information for this product. cysview is an optical imaging agent indicated for the symptomatic detection of bladder cancer, including carcinoma in situ, which is an aggressive type of tumor, in patients that are suspected or known to have bladder cancer based on previous imaging. So Antonio is going to give the refresher on the training today, and thank you for being here. I thank you for coordinating with us, Trisha and Serena.
Thanks for the hospitality.
Hey everybody, I'm Antonio. I'm the business manager for PhotoCure, and we only deal with cysview. So Angela is going to be your main primary contact, but I travel around the boring states and the flyovers in the Midwest and give presentations and information on cysview, but more specifically blue light cystoscopy. This is used only by the urology department. I think everybody's probably aware of that. And some of you might be sitting here thinking, I heard of this, or maybe did an installation once, but we haven't even been using this. So why in the world are we doing an in-service on it? No, yes, no. No one wants to admit it, but yeah, maybe. So the reason is a couple good things. Number one, University of Michigan Medicine as a whole has decided to join our bladder cancer patient registry, which is the largest registry of bladder cancer patients in the entire nation. So we collect data on the disease state of non-muscle invasive patients. And as you know, a lot of these patients who have bladder cancer are coming back every 3 months or every 6 months, and it takes a long time to manage that cancer and try to make sure it doesn't recur or progress. So we're going to talk a little bit about the product, why we use this, maybe who's using it here, and what that means for the preoperative department. As Angela stated, this is a product that's used specifically for not diagnosis, but what's the word I'm trying to come up with? It's used as an optical imaging agent for the detection, and this is a diagnostic, not a therapeutic. So we're not going in there like a laser system and finding the cancer, lighting it up and blasting with a laser and treating it. You're finding margins or lesions that otherwise weren't visible in white light. So the indication is it's a drug device combo. It's used here in pre-op as an installation of the medication into the bladder. And then there's a secondary part back in the operating room that is the Karl Storz cystoscope, and that has a specific blue light, and that's what makes these potentially cancerous cells light up bright pink. So let's take a look at what it means. Has anybody had a chance to go back into the OR and see one of these procedures live? Most people just see it from out here. So you do the installation, and then the patient gets whisked back off to the OR, and you probably think, what in the world does it do back there? What happens? So these are some nice images of the inside of a bladder that traditionally would be seen with white light cystoscopy. So you can probably tell there are some abnormalities. You can see some vascularity in the pictures, but most importantly, some of the lesions are probably difficult to detect based on the images that you see up there. This is at the end of a cystoscope looking directly at part of the bladder in areas that were already suspicious. So if you look at this, you can probably tell there's a couple lesions there. But then if you take a look at it after you instill the medication, it dwells and they light it up, you can see there's that additional satellite lesion up top. So this helps the physician in two ways. Number one, you found an extra little lesion up top, but also to grab all the margins and make sure you've resected all of those areas that potentially could be suspicious for cancer. Second one, this one's hard to see. Can you guys see that from back there? I would say you might even miss that. But this tiny little speck there is an opportunity to resect something that was otherwise not visible. And so as those patients come back and the doc says, well, hey, unfortunately, we've got a positive test, we've got to go in and look around again. This is increasing the opportunity for sensitivity and visualization inside the patient's bladder. Next one down below, you can probably see something right in the middle, but as a bladder scan happens kind of quickly, that's something too that potentially could be missed. And this is an example of an inflamed bladder. So somebody that needs to either come off of a chemotherapy agent or had rounds of BCG treatment. And this is inflamed and maybe diseased in other ways. Infection lights up occasionally bright red, but as you can see down in the bottom right and even over in the left, there are small lesions that are suspicious for cancer. So we like to show you that because I know a lot of folks don't have the opportunity to go back into the OR, and this essentially is why we're doing this for the patients, so that there's more opportunity for them to come back with the good news that, hey, we think you got it all this time. So this is what the kit looks like. You may or may not be familiar with this, so it's a little bit different in this institution than others. A lot of times we reconstitute this medication bedside. And since pharmacy is reconstituting this for you, we won't go through the specific steps, but this is probably one of the most important parts of the kit. I'm guessing the syringe shows up like this, pre-filled, ready to go with the plunger in the back, and then you get this. Is that correct? How many of you have done an installation here? How many? Just a few of you? Okay. So this is the important part because this is going to be your transition from your Luer lock at the end of the syringe into the catheter opening. When you have this product, it opens at both ends. You're probably familiar with this, that you need to even stock this separately, but I like to open it from the end that's going to allow you to still hold the side that's entering the catheter inside the packaging, and then just split down the bottom. And at that point, you can remove the cap and twist this onto the syringe, and it's a full push into the bladder for the entire bit of the medication. This isn't really the hard part. I think the hardest part here is timing and logistics. Timing and logistics is communication, coordination back with the OR as to when does this have to go in and how long does it have to be in there so that we make sure that it's ready for the next patient. I know that in the past it's been difficult when you've got a case that's boarded for a certain amount of time and then all of a sudden you get the notification, we're closing in 5 minutes, and then the cysview hasn't had enough time to dwell in the bladder. So I'm going to go through just a little bit about the timing, what's appropriate for it, and then maybe that'll help with communication back to the operating room. When I talked to the OR, they blamed it on you guys, so I'm assuming you guys are going to blame it on them. No, I'm just kidding. I don't think it's the same as when you talk to the physicians, they blame it on anesthesia, and the anesthesia is like, it's not. So let's talk about the catheters. So what can you use for this? Got the catheter there? Okay, so there are catheters that are appropriate for this and catheters that are not appropriate for this. So what you're going to use here is a standard supply room catheter, 14 French, and you've got a couple options. Straight or intermittent are okay. You can use something with the Luer lock capability, but most often it's not going to go directly from the syringe. Like I said, it's going to use this catheter tip here. Vinyl, latex, or silicone are fine as long as they are not coated with antibiotics or silver. So that means when you have patients that come in and they already have a catheter in them, they say, hey, I've got a catheter, can you just put it through here? The answer, unfortunately, is no. That catheter would need to be removed and it needs to be replaced with a new one from your facility. As far as the items and details of the cath itself, you're going to use your standard cath procedure, whether that just be a betadine wipe, standard prep, drape, and insertion of the catheter. There's really no reason immediately to keep the bag attached, and your options are to either insert, deploy the entire medication at 50 mLs and pull the straight cath back out if the doctor recommends that. But more commonly, you're going to put it in and then leave it in, correct? If you're asked to use a Foley, you put it in, clamp it, and then the medication will dwell all the way until they go back into surgery.
Yeah, we have the clams in the stock room.
No, but how can you hold that in? Because that doesn't have a.
We do.
These don't stay.
The you're gonna take out. If
That-
you do a Foley, you're gonna keep it in, and we should have.
You just
the
said
clamp.
that anything that we can.
No, you got two options.
Two
The
options.
two options are either straight cath,
So
so you go in and out, or you can use a Foley catheter and clamp it and leave it in there.
the one that's going to stay has to have a balloon, obviously, because this will slide right out. Yeah.
So it's,
Typically just ask the patient, can you hold it in your bladder? If they can, you can use an ISC. If they can't, then you're gonna use the hold it.
I know most of these patients have a history of incontinence, but just for volume perspective, this is 50 ml. So everyone knows what 50 mLs looks like. It's important once you cath them to make sure the bladder's drained entirely and they void their urine completely. If you're working up the patient in the initial setting and you say, hey, have you gone to the bathroom yet today? And they haven't, it might be a smart idea to either have them go to the bathroom or ambulate them to the bathroom and have them void completely as much as they can, and then remove all the rest of the urine with one of these catheters into either bedpan or bag after you cath them before you install medication. Okay, questions on that? So I would say most of the physicians here that are going to use this, either Dr. Kaffenberger, Dr. Morgan, Dr. Harrell, maybe Dr. Montgomery, are going to order a cath for the patient that most likely would be a Foley with a clamp. However, our literature says that it should be straight cathed in and then put back out. Now, a couple specifics on once you cath the patients or before you cath the patients, any contraindication to this should have been ruled out by the physician before they even come into surgery, except for one thing, and that's gross hematuria. Does anybody know what porphyria is? It's a condition that's overproducing porphyrins within the body, and it's contraindicated for this medication because this medication also encourages extra porphyrin production. And so really, if the patient had that condition, this medication wouldn't work. So if they have that, they're not a candidate for cysview. But again, that's something that the physician would know ahead of time. The one thing that you want to look out for is gross hematuria. So if the patient comes in and they're bleeding a little bit, that's okay. But if they're bleeding profusely, you probably should call back and ask the physician before you instill this medication. It's not that it will interact with the drug, it's just that you won't have any visibility. So the goal is to see tumors. And if the patient is just filled completely with blood at the time, then it will prohibit them visualizing what they need to see. And then known hypersensitivity to that long word, which is the drug itself, it's called hexaminolevulinate, but the brand name is cysview.
So if we put in the Foley and we see blood coming out, is that okay? Or should we just contact them further?
I would say it's at your discretion if you would consider that gross hematuria. In a lot of cases, you've got patients that are either cathing themselves or they've had some trauma previously to the urethra or their passage as a whole. And if there's some blood, we see that commonly. But if it's what you would consider gross hematuria or just full of blood, I absolutely would call it a medication. Okay, precautions as far as how you're going to handle this. It's just an aseptic technique. So you don't have to worry about going and getting sterile specific gloves or setting up a sterile field. Standard aseptic technique with just gloves off of the wall. You want to avoid any contact with your skin with cysview itself. And if it does come into contact, our protocol is just to wash with a soap and water mix. And that's the same for the patient's skin. So if you're putting it into the patient and you remove the catheter, if you decide to do as a straight cath and it spills out onto the patient's skin, it's just a soap and water wash. There haven't been any specific adverse reactions to skin other than just a small rash. This is not a chemotherapy agent, so you don't have to worry about a hooded handling of this, and there are no additional special precautions for handling. Questions on that? All right, so this is what we talked about. Void the urine first from the patient. Step 2, assemble the catheter kit, either Luer lock adapter, either Foley or straight or intermittent catheter. You insert the catheter. This says sterile technique, but again, aseptic. Don't worry about sterile gloves. The solution should be instilled slowly. So this is a straight, slow push of the entire medication. If you do that and the patient feels like they have to void immediately, and let's say you went for a straight cath and you pull the catheter out and the patient expels the medication, there's no redosing same day. So this goes in one time, and no matter how much they retain in their bladder, you can only put it in once. At that point, if you picture the bladder, I know a lot of times when you see a picture of the bladder, it's like this nice, perfectly round, awesome looking bladder that has a nice lining, but in actuality, your bladder is kind of flat like a pancake if it's not distended or has medication. So once you put that in, it just kind of bumps up a little bit. If there is a small layer of medication in there, then it will be coating the majority of the surface of the bladder without issue. So even if there's a small amount, you're not going to redose. Question? The only reason why it's the same concentration of solution. So it's 50 mLs and the dosage is 100 milligrams. It's always 100 milligrams, so it's 2 milligrams per milliliter. So you have the same concentration.
What is negative for the patient?
Well, it's not, but I have to translate the information specifically from our prescribing information. And in our clinical trials, we didn't try to redose the patients. So that's the answer. Yeah. Go ahead. It's a good question and we get it a lot, but no. And I know there are a lot of things in chemotherapy agents where you spin them, half side to side. And in this case, that won't be necessary. If you voided the bladder completely and there's no other irrigation in there, cysview should be at the time the only thing in the bladder plus a little bit of urine. And it just remains in the bladder as such and they can stay on the ground. Okay, timing. So this is the hard part. Trying to figure out when the OR is actually ready for you. I'm going to start with the maximum amount and we'll go back to the minimum amount. The nice thing about this product is it can be in there for a full 3 hours. So you're probably not ever too far ahead of time because if the patient's only coming in 2 hours before surgery, when they come in, you could technically put that in the patient right away and it can stay in there for the full hour or full 2 hours. So if you're trying to have them wait and time it so it's exactly an hour, your 1 to 3 hour window is the sweet spot. So I would err on the side of it can go in sooner unless there's a huge delay. So the examination of this needs to happen 1 to 3 hours after the installation, which means they don't necessarily need to sit in the, you call it PACU or pre-op, in the pre-op bay for the entire hour before the procedure. So let's say the patient comes in, you begin their workup, you've got consent going, you start their IV, for instance. I might just do it on like a TKO so that they don't produce a whole bunch more urine. And then once that happens, you're ready to do the installation. And then all of a sudden they call back and say, hey, we've got 30 minutes. If you put that medication in right away and there's the 30 minutes, then they wheel them back between transport, intubation, draping, prep, and finally putting the scope in. You're going to be pretty close to an hour, but that's cutting it close. So I would recommend trying to do it a little bit sooner, maybe even just before the IV. I don't want to mess up protocol or whatever you have going on here, but just keep in mind that if they say this case is going 2 hours from now, as long as it's between 1 and 3 hours or they're in the bay for at least 45 minutes, by the time they start the examination, it'll be right at about an hour. And I think everybody already knows this, but you don't have to evacuate the medication before you send them back. You don't have to worry about pulling the catheter, pulling the Foley out, and then voiding it into a bag or a bedpan. You can send them straight back with a Foley in if that's what they have. And the first thing they're going to do is void the medication when they start the procedure. All right, so let's say something else strange happens and they go, you know what? We've got a big robot case that's lasting too long and this patient's not going back for 4 hours. And so you're kind of waiting, but you already put the medication in and you know that it's going to lapse the 3 hours. If the patient has been sitting, and I know this is uncommon, but if it does happen, the patient's been sitting in pre-op and they have the medication dwelling and it's going to pass the 3 hour mark for whatever reason, you can have them void. Again, don't redose, but you're still going to send them back to the procedure. At that point, the medication will have already done its work and has already changed the enzymes within the cells to make those cells glow bright pink, and they can go back and they'll have the same result. So it doesn't need to be in the bladder when they go back there if for some reason you've lapsed the amount of time.
How long does it last?
The effect, the product itself, you have about 20 to 30 minutes of actual visualization in the case until the irrigation has moved the majority of it out of there. The converse of that, let's say everybody's going really fast and you need to wheel the patient back. Let's say you put the product in and it's only been 20 minutes and they say, you know what, it doesn't matter, we're ready for them right now. It's at the doctor's discretion. We say it needs to be in there for 1 hour, but if the physician says, I don't want this to back up my day, and by the time they get back there and we start the procedure, it's only been 40 minutes. This isn't like a hard, fast set, okay, you know, if it hasn't been an hour, it's not going to work. You may have some fluorescence and some visualization. It may just not be that bright. So I would keep that in mind. If the physician's orders are, I'm ready for the patient right now, it's not imperative that you retain them here in order for it to activate at a certain hour mark. but that is the recommendation of our prescribing information. As a physician, they're welcome to use that how they wish. Questions on that? All right. Post-installation, this is just kind of everything we talked about. If the patient didn't retain for an entire hour, if you put it in and they expel it everywhere and they void, you're still going to have that hour period for that medication, whatever's left in there, to work before they go back to the procedure. And then the one other thing that we didn't talk about is if cysview comes to you and something happens, let's say the patient wasn't NPO, or their blood pressure is too high, or the pregnancy test came back, anything happens where the case gets canceled, but for some reason cysview was already reconstituted. If you happen to have another case that day, the medication can go into the refrigerator for up to 2 hours. And after 2 hours, it does need to be discarded. But let's say you do have 2 blue light cases and they happen to be back to back, rare, but if it happens, then you can use that medication on the next patient as long as it's refrigerated for those 2 hours. So you might be asking yourself, well, if this isn't a chemotherapy agent, then what is it and how does it work? And 2 fun facts are, it's not a dye and it's not a contrast. And so for the patients that say, I can't have that, I'm not allowed to have dye, I know that I had that previously and I'm allergic to it, that's not applicable to this product. And the reason why is because it's classified as an imaging agent and actually changed the enzymatic activity of the cells. So if you remember all the way back to biology class, everybody's familiar with this diagram, right? No. Okay, so this is the mitochondria of the cell, and it's the heme pathway. So if you want to talk technical for a little bit, what does cysview actually do? It interacts with the biosynthesis pathway of heme, and it actually, just prior to heme production, it changes the enzymes where more photoactive porphyrins are accumulating inside the cells themselves. And so does cysview light up and create this dye or image by itself of these bright pink cells? No, it's actually porphyrins that are already naturally occurring in your body that are lighting up. So all we're doing is we're acting as a catalyst inside the bladder to make sure those porphyrins accumulate in cells, and it takes preferential treatment to those because they're accumulating it faster than the tissue around it. So it makes sense to everybody, right, to think that healthy tissue is just going to metabolize at a regular rate. And we know that cancer is aggressive and proliferates more aggressively because those cells are metabolizing faster than the healthy tissue around it. So anything that potentially could be cancerous, cysview takes preferential treatment to that, changes the enzymes, makes them accumulate a whole bunch of porphyrins, and then under the special light back in OR, that's what lights up right there. That's how it works. So if you want to regurgitate that, explain to every patient that comes in. I'm just kidding. We actually have some nice pamphlets for you that are patient guide, and it says that in layman's terms. So if someone comes in and they haven't had this procedure before, they have an opportunity to learn about it and see some of those fun pictures. And so when they're questioning you as to why am I getting a catheter right now in pre-op, I've been back for a cysto a whole bunch of times and I've never had to do this before. It should help, hopefully, ease their mind and then prevent you having to explain the entire procedure over to them in pre-op.
Be the first time they're going to hear about this?
No, so our job is to make sure that we work with the schedulers and the physicians up in the clinic. And before these procedures, they receive a paper that explains blue light cystoscopy. The physician should be discussing with them. But alas, everybody knows by the time they get here into your bay, they have completely forgotten. And then they tell you, no one told me about this. I have no idea that I was supposed to get this. And then you're tasked with re-explaining everything. So we're going to try to prevent that. That's never happened, right? So, but it is kind of a shocker to come into the pre-op bay and then all of a sudden you're like, actually, you're going to have a catheter, while you're awake here, and their loved ones sitting there, and then they've got a bunch of questions for you. So we're going to work hard to try and go and start at the ground level. When they first get boarded for this appointment, we have both digital and hard copies of information that's supposed to go to the patients. We've communicated with the physicians, and then we're also going to leave some with you. Do you have one with you, Angela, right now?
Yeah.
And it's a nice little brochure, and it says a patient's guide to blue light cystoscopy. So when you're about to give the catheter, you can hand the guide over to the patient and say, go ahead and review this. And then while they digest that information, you can prep the catheter and call for a cysview from pharmacy.
Is there a big sticker on it that we write the time we instilled?
attached to something? Is there some type of?
So the sticker that's on here is actually the time that it was reconstituted, and so pharmacy does that, but the time that it was instilled should just be put on the chart or in the MAR. Do you use the MAR here?
Yeah.
Okay,
Yeah.
so it's just put into the system directly, but it's not on the syringe itself. This product, since it's not a chemotherapy or dye, doesn't have any special disposal. It needs either, and so this just can be discarded when you're finished with it. It hasn't been studied on pregnant or nursing mothers. Obviously, we haven't used this on peds. Our primary population is, of course, geriatric, being its bladder cancer.
How long has been
The product itself has been around for over a decade, and University of Michigan has been using it for about 7 years. So it's like we're not introducing something new. We're just kind of rediscussing with the bladder registry something old. And, you know, given that this is what you see back in the operating room, probably looks familiar with a lot of cystoscopes, but this equipment now is also about 7 years old, and potentially, you know, could be upgraded to new products for increased detection. But for right now, this is the same platform they're using back there. And that's all I've got. We take part in the Bladder Cancer Advocacy Network and other research organizations. If you want more information, you can always go to our website, cysview, but we'll do everything that we possibly can to make sure that the patients are aware and informed of this before they come to you.
We try to help sort of the reoccurrence, as actually a reoccurrence and not like something in this.
Yeah, that's exactly right. Yeah, this is not a replacement for their random bladder biopsies, and it's used as an adjunct to white light. So they would go in. This tower that I showed you is capable of both. So they start with the white light cystoscopy. They switch back and forth between blue light and white light, depending on what they need at the time. And they can still take random bladder biopsies, but this gives you a more targeted approach that does two things: either lights up cells that otherwise weren't visible, or number two, like you said, if there's a large area, let's say you go to resect all that, but you didn't realize there was one extra little piece. How do you know if that is a recurrence or if that was just residual left behind? So that's what we're aiming to make more precise are both the large lesions and the lesions that you can't see.
Or
It is preference, but it's indicated for all. So it could be used just on suspicion. So the nice thing about this is if someone comes in and they present in the clinic with just hematuria and they have a workup done and they're going in for their very first procedure ever, you can use this. If they're coming back years later for restaging and regrading of their disease state, this is also indicated for that. So it really is from suspicion, meaning they never had a diagnosis of bladder cancer, all the way from low grade to high grade disease.
More prominent in men or women usage, or about the same?
It's just inherently more prominent in men, just because there are more men with bladder cancer than there are women. So just statistically, you end up seeing more men with it. Any other questions? Yeah, so spasms.
we don't redose.
You don't redose. Yeah, if you instill the whole medication and for some reason they spasm, obviously if you got a Foley anchored in there, it's probably not going to blast out. But if it does come out the Foley as you remove the syringe, even before it's clamped, still no redosing. Any events after these procedures have been very consistent with the regular transurethral resection, even without this product. So burning, pain, sensitivity, bladder spasm. But this product has a very neutral pH and is room temperature. And so it shouldn't, it's not cold and it's not acidic. It doesn't burn, it doesn't hurt. And so it really shouldn't affect the bladder other than the uncomfortable feeling of it coming in. Thanks.
Yeah. Feels cold as you.
Yeah, if it comes out of the fridge, if you got that rare instance where you have two patients and you had to refrigerate it, there was a delay and you go to put it in, I would absolutely recommend warming that up in your hands before you put it into the patient. Out of the 6 years that I've been here doing this, I don't think I've ever seen a medication been refrigerated and go back into the patient. It's just part of our protocol. Anything else you want to know? All right, thanks for your time.
Thank you.
Appreciate you having us.
Very good.
Any questions on Zoom? Thanks, everybody, for zooming in. Right, yeah.
Oh, did you? No, no problem. We actually,
Not with.
oh, did you? We, when Dr. Alani was there, remember for the Alani? See what the DMC. Yeah.